not only India, not only in the not only India but around the world. Hypertension is one of the diseases. Only 1/3 of the patients know they have hypertension, and after 1/3, only 1/3 take treatment for that, and after 1/3, only 1/3 take drugs regularly, and their BP is under control. And in spite of that, only 1/3 of the patients remain from complications. Just as in diabetes, in hypertension also, the latest thing is right from day one, to diagnose hypertension, we focus on not only bringing down the numbers in BP, but also protect the heart and the kidney from the ethos of hypertension. That's very important, right from day one. So, how to ensure that your patient's heart and kidney are safe? We know hypertension, most of the time, the death due to hypertension occurs due to CV events and due to kidney failure. How to protect them right from day one? That's exactly what I'll be talking to you in the next 30-40 minutes. And we go now into the talk. This is the prevalence of hypertension in India. It's estimated from various studies that the prevalence of hypertension in India is 29.8%. It's estimated that about 8% of the hypertension patients are controlled in India, only 8% of all hypertensions. And 92% of Indian hypertensive patients are either uncontrolled or not controlled. This is a 2014 data. The data which is in 2020 from WHO for hypertension in India is still more alarming. It says 1 in 3 1 in 3 of the adult population of India have hypertension, and only 18% of the people are under control. And if this goes on and on, in future, hypertension is one of the major killers in the form of CV diseases and kidney diseases. That's what the WHO is warning as far as India is concerned. So this is the prevalence of hypertension in India. And we know uncontrolled hypertension causes premature death. Hypertension is one disease just by controlling which we can prevent a premature death. There's one disease is hypertension. We know hypertension usually causes heart attacks, it causes strokes, kidney failure, blindness, and other complications. In fact, CV events are the most common result of uncontrolled hypertension. Patients die more often due to stroke, a major stroke, maybe either hemorrhagic or ischemic stroke. In fact, 58% of the patients, 58% of them patients with uncontrolled hypertension have got a stroke or a ischemic heart disease. It affects the heart in the form of a major heart attack or heart failure in about 30% of the patients, and about 24% of the patients they have got chronic kidney failure. And about hypertensive ophthalmopathy, we know much about it. It's a very silent thing which just creeps under you and suddenly strikes you like a tsunami. So we should be aware of all these things. We know about this cardiorenal continuum. This is being talked about more frequently in the recent days as hypertension and other risk factors like diabetes, obesity, and elderly. They progress in the patient's life. The heart and the kidney go in tandem along with each other. Kidney, whatever affects kidney affects the heart also. Whatever affects the kidney, the heart affects the kidney also. They run parallel together. Hypertension, especially in the heart in the CV system, it forms atherosclerosis and LVH. It causes myocardial infarction and stroke. And there's remodeling of the heart muscles. There's ventricular dilatation, cognitive dysfunction in the brain. There's congestive heart failure and secondary stroke in the brain. And at last, end-stage heart disease and brain damage and dementia and CV death occurs. This as far as heart is concerned. In the kidney, it proceeds from endothelial dysfunction, from microalbuminuria to macroproteinuria, nephrotic proteinuria, and it results in end-stage renal disease. And before the kidney can claim, he dies of a CV event most of the times. And this is how we should intervene in a patient with cardiorenal continuum. We should strike right at the left-hand corner. You should prevent the risk factors, especially high risk factors. Is a smoker, is a diabetic, he's got dyslipidemia, is obese, ask him to reduce weight. Should prevent the continuum from progressing as a first aim of you. Once the patient develops target organ damage, which is asymptomatic, that's stage number 2. Target organ damage which is asymptomatic, and angina, which is symptomatic, of course, but when there's atherosclerosis, when it's microalbuminuria, all these things, then we should regress the disease what has happened already. And when it's advanced stage, there's target damage, which is symptomatic, and you should prevent at least here. You should try to retard the progress of cardinal continuum and prevent ESRD in death. This is the rough plan which will be proceeding in this talk. The first and the foremost one is prevention. Second is regress the target damage, which is asymptomatic, and retard that target damage, which is symptomatic. And hypertension is causing such a big havoc, we know about it. And if diabetes also goes with it, they two together, they have a lot of deleterious effects, we know about it. Globally, 285 million individuals, 6% of the whole population are diabetics. It's projected to rise to 413 million by the year 2030. And globally, hypertension is 972 individuals. 26% of the world population has got hypertension. It's projected to increase to 1.56 billion. Just imagine, number is so alarming, which goes to 29% of the people in the world will be having hypertension by the year 2030. 1 in 3 again, as it is now in India. And when they combine together, 40 to 80% of diabetics have got hypertension, and diabetics 2 times they are more likely to develop hypertension. So when they two combine together, there's 70% are more end-stage disease in the US attributed to hypertension and diabetes. There's increased risk of retinopathy, and in the heart, there's 3 times likely to have. And in the heart, there's 3 times likely to have coronary heart disease, 2 times likely to have LVH, 3 times likely to develop congestive heart failure. And peripheral vascular diseases also are very rampant when both are combined together. And in the brain, there's 2 times the risk of stroke. So, but we usually have a combination of hypertension and diabetes many a time, and it's really a lethal combination. Unless you take the first stage itself, we should prevent these things. So only it becomes very imperative that when you're diagnosed with hypertension, the BP is high, when you confirm you've got hypertension, immediately you should look for its fasting sugar, blood sugar, HbA1c, should do an ECG, should go for microalbuminuria to set the kidney or urea, and everything is a must. And all these things should go at a package. Even in a diabetic, you should do all these things to prevent such diseases and to be on guard. And lifestyle changes to ensure cardiovascular interception. This is very important. Unless you ask a patient to follow this, there's no use going to advanced drugs. Dietary changes, the dietary the DASH diet is so very important in hypertension. Salt restriction is very important. WHO and the various bodies, they advise you not to take more than 5 grams of sodium chloride per day. Regular physical activity, its importance cannot be overstressed. It's so important. Weight reduction, you reduce 1 kilogram weight, your BP comes down by 2 millimeter. That's the equation. Smoking cessation, smoking is one thing which is much more important than any of the drugs which you give. You should always talk to a patient, ask him to stop smoking. Alcohol in moderation, and reducing stress. Stress, which is the root cause of all these things. Because of stress, there is a sympathetic overactivity, and that leads to insulin resistance, and all the other comes as a package, like dyslipidemia, obesity, diabetes, hypertension. So reducing stress is one very important thing. And of course, you should avoid drugs which may damage the kidney at any point of time. So this life, then what are the guideline recommendations for hypertension? We'll have a quick look at that. We know, we have seen it many times. There's just a quick refreshing. The International Society of Hypertension, Global Hypertension Practice Guidelines 2020. This is the latest guidelines. This article has been co-published by Hypertension, Journal of Hypertension by Unger et al. 2020 ISH Global Hypertension Practice Guidelines. It says that there are 2 important divisions. One is essential recommendations. Next is the optimal recommendations. Essential recommendations are at least all patients should get it. It's a minimum standard of care. And optimal recommendations are recommendations which are evidence-based standard of care. So when you establish a diagnosis of hypertension, first treatment is lifestyle advice, as I already told you. Then when the patient has got grade 1 hypertension, grade 1 is which is BP systolic 140 to 159 and diastolic 90 to 99. In that, immediate drug treatment in high-risk patients are those with CVD, CKD, DMR, hypertension-mediated organ damage. as per the ISH guidelines, the patient's BP is 140 to 160 systolic and diastolic 90 to 80. If the patient has got any risk factors like diabetes or CKD or macular, or is a smoker, is obese, then we should start treatment immediately. But when there are no risk factors, you can wait for some time, at least 2 to 3 weeks or 2 to 3 months, and ask them to follow strict guidelines, lifestyle modifications. And if they is able to reduce the BP, then it's okay. Ask him to continue lifestyle modifications, or else you can put him on drugs. This is what they say. The essential guidelines are limited drug availability. There's limited drug availability in those at lower risk. Supply lifestyle intervention for 3 to 6 months. If BP is still not controlled, and where possible, start drug treatment in those aged 50 to 80 years. Optimal is drug treatment in low to moderate risk patients without CVD, CKD, DM, and hypertension moderated organ damage after 3 to 6 months of lifestyle intervention if BP is not under control. But in my patients, if even in grade 1, if even they have one risk factor, I immediately start them on treatment, because it's very tough to get the patient again. We know hypertension is essentially a asymptomatic disease. He will live happily, and suddenly come to BP of 200 by 120. So right from that day, starting treatment, mild dose, of course. And grade 2 hypertension is BP is more equal to or more than 160/100. In both the essential optimal guidelines, they said immediate drug treatment is in all these patients when the BP exceeds 160/100. And the core drug treatment strategy will be use whatever drugs are available with as many as ideal characteristics. Use free combinations if single pill combinations are not available or unaffordable. ISH and all the associations, they recommend very strongly to use ideally single pill combination therapy, and use thiazolidinetics if thiazolidinetics like diagnosis are not available. Use alternate to DHP, CCPs if they are not available or not tolerated. Optimal will be right from the day one, you start on a dual low dose combination of ACE inhibitor or ARB plus calcium channel blocker. If it's not effect, then at the step 2, give them full dose of combination ARB ACE inhibitors plus calcium channel blockers. As step 3, if still BP is not under control, you could go for a triple combination of ACE inhibitors or ARBs plus calcium channel blockers and a diuretic, which preferably is a non-thiazide diuretic, thiazide-like diuretics. And as step 4, still if the BP is not under control, resistant hypertension. Resistant hypertension is defined as hypertension which is not under control, even when you use the maximum number of at least 3 drugs, and one of those drugs should be a diuretic. That's resistant hypertension definition. There use a triple combination plus spironolactone or other drugs. Spironolactone 12.4 to 15 milligram you can go. And still if the BP is not under control, refer him to a hypertension specialist. This is what the recommendations say. You can see that there is no place for beta blockers here. Beta blockers come as the first line of drug. The patient has a CV morbidity, comorbidity. If he has angina or if he had an infarction or heart failure, beta blockers will come first to the place. You go for highly selective beta blockers like metoprolol or nebivolol or bisoprolol. Otherwise, there is no place for beta blockers in this thing. And as per the ISS 2020 guidelines, the ideal characteristic of the drug treatment will be treatment should be evidence-based in relation to morbidity mortality prevention. Should use once daily regimen which provides 24-hour blood pressure control. Treatment should be affordable and are cost-effective relative to other agents. Treatment should be well tolerated, and evidence of benefits of use of medication in populations to which it is to be applied. All these things are very important. This is again the initial single pill combination. All the associates I told you, they recommend this. The BP can be a bit lower, the normal BP for Americans, and for Europeans a bit higher. Americans, they say average BP of 130/90 BP, whereas Europeans and Indians say more than 140/90 is stage 1 hypertension. And in all the stages, the initial combination is the initial single pill combination therapy in patients, to which if the BP is more than 20/10 systolic and diastolic, you should use initial single pill right from day 1. Should start with a single pill combination. And the initial single pill combination, if therapy in patients who have BP of more than 140/90 as per European Society is concerned. This is what the guidelines say. And do they recommend in his special drugs. Now I'll show you the latest guidelines which have come in 2021, the 21st European meeting on hypertension and cardiovascular prevention 2011. This shows very clearly that hypertension patients need simultaneous renal and cardiovascular protection to prevent cardiorenal damage. This is what I've been telling you right from the start. This is the 2021, sorry, it's not 2011, 2021 guidelines, 21st European meeting, hypertension and cardiovascular prevention. It says that hypertensive patients need simultaneous renal and cardiovascular protection to prevent cardiorenal damage. Modifiable risk factors such as dyslipidemia, diabetes, and smoking are major contributors to both CKD and CV events. In addition to standard lifestyle modifications designed to control these risk factors, the use of antihypertensive therapies that provide simultaneous renal and CV protection is critical for improving outcomes among patients with hypertension and CKD. So right from day one, you should start drugs which provide simultaneous renal and CV protection. This is very critical. That's what they are. There drugs available for that? Yes, that's what I'll be going to talk to you now. The US FDA has approved telmisartan, and the PMDA, Pharmaceuticals and Medical Council agency, have approved acylnitropine. How they qualify for to protect kidneys and the heart right from day one, that we'll be seeing just now. This is the method of mechanism of action of both telmisartan and acylnitropine. Telmisartan, we know, is a ARB, angiotensin enzyme converter angiotensin 1 and angiotensin 2. At the level of angiotensin, renin blocks it, angiotensin 1 and ACE. They convert angiotensin 1 to angiotensin 2, and angiotensin 2 is broken to angiotensin 1 receptor and 2 receptor. Telmisartan comes at that place, and angiotensin 1 receptor leads to vasoconstriction, fluid retention, cardiac remodeling. This is being prevented effectively by telmisartan. Acylnitropine blocks L-type and T-type calcium channels. So there's inward movement of calcium is stopped in these. Relaxation of smooth muscle cells of arterioles occurs, and blood pressure is lowered. Acylnitropine is no, it blocks L and T-type calcium channels. What are the L and T-type calcium channels? I know there are so many calcium channels. At least 6 are there. You got L-type, N-type, T-type. Others are there. And the commonest drug which you've been using for hypertension, amlodipine, it acts on L-type calcium channel. It blocks the calcium entry in the intracellular space. Thereby, it blocks the influx of calcium in muscular and smooth muscle and cardiac muscle, decreased muscular contraction, the reduced cardiac contraction, reduced cardiac output, and reduced blood pressure. There's a pathway for creating for the lowering hypertension in the drug amlodipine, which acts exclusively on the L-type channel. L-type calcium channels are predominantly expressed in the hearts and the peripheral vasculature and serve as the preferred molecular target of the initial calcium ion channel antagonists in the treatment of hypertension. And then, but the one drawback with this is the action of L-type calcium channel blockers is it increases precapillary resistance, it decreases it causes extraction of fluid, and it causes pedal edema. This is partly overcome by N-type calcium channel blocker cilnidipine. Cilnidipine, which acts both on L-type and N-type channels. As far as N-type calcium channel is concerned, it causes vasoconstriction, increase of cardiac contraction, increase of heart rate, and decrease of renal blood flow, and renal secretion. All these being reversed by cilnidipine. So it acts on, cilnidipine acts both on L-type and N-type channels. Only it's called as LN block by the N company, the product of cilnidipine. But our hero today is acylnitropine, which acts on L-type channel and T-type channel. The L-type channel, as you know, it acts on the large vessels only, and it goes and it doesn't usually block the small vessels, micro vessels. And we know micro vessels are much more important in the reducing BP than the larger vessels. And when L-type channels act only on large vessels, it causes undesired vascular effect, glomerular hypertension, and vascular edema. Whereas L and T-type channel calcium channel blockers, when they act combined, it acts on the macrovasculature also. It reduces calcium entry, cell proliferation, and vascular contractility. It gives neuroprotection, edema removal, undesired effect, and drug interaction. blood pressure control is affected very effectively with this combination. So advantages of combined LT type calcium channel block, this over L type. Inhibition of L type calcium channels causes dilatation of afferent but not efferent arterioles, which potentially results in glomerular hypertension. The LT type blockers are superior to L type channels calcium in renal microcirculation. LT type calcium channel blockers equalize, this is very important, they equalize the hydrostatic pressure in capillaries through equal arteriolar and venous dilatation. This results in lower chances of edema. L-type blockers, they block the large vessels and leads to glomerular hypertension and vascular edema, whereas L and T-type blockers, they act both on large vessels and the microvessels, reduce calcium entry, good BP control, and it gives renal protection and low risk of edema. This is how it happens. Acylindipine, both L and D block it. It dilates both afferent and efferent arterioles. There's reduction in glomerular capillary pressure and more potent than L-type calcium channel blockers in reducing proteinuria and the subsequent production to CKD. So whereas when you block only the L-type, afferent is constricted, efferent is not, so it leads to increase in the intraglomerular pressure. This again explains very clearly in the heart. The L-type blocker channels decrease contractility, increase pulse rate, and increase glomerular pressure. Whereas in the N-type, they decrease heart rate, they decrease pulse rate, and decrease glomerular pressure. The T-type blockers, they decrease heart rate, they decrease pulse rate, decrease glomerular pressure, and in addition to it, as a bonus, it decreases the aldosterone secretion. Only LT type calcium channel blockers, acylindipine, reduce aldosterone secretion as compared to other LN type CCBs. So the drugs, nifedipine acts on L type and not on N type and T type blockers. Amlodipine acts only on L type. This I've been telling you just now. N type and T type is not acting. Cilindipine acts on both L type and N type, but it doesn't act on T type blockers. Acylindipine acts on L type channels and T type channels and not on N type channels. So acylindipine does not induce reflex tachycardia, which is very important. Tachycardia, which usually occurs in people with amlodipine, is not there. Probably since it elicits a gradual BP fall in 24-hour control. And the important thing is, we as Indians, we got a increased the resting pulse rate and resting heart rate. This has been found in very large studies. In fact, in the India heart study in India, which was conducted a few years back, told very clearly that we Indians suffer from increase in resting heart rate, which directly increases the risk for major CV events. And the drug which are going to give for hypertension, if it's all going to increase the heart rate and produce tachycardia, it's not that much nice, isn't it? So whereas acylindipine, it does not induce reflex tachycardia. It elicits a gradual fall in BP within 24-hour control. Significantly reduces heart rate and proteinuria in hypertension patients by suppressing sympathetic nerve activity. This again, I told you, sympathetic nerve stimulation is considered to be the most important thing now to produce insulin resistance, to produce diabetes, dyslipidemia, and a host of such diseases. That being suppressed by these L-type, T-type channels is very good news for all of us. Acylindipine has also been confirmed to have cardioprotective, cerebroprotective, from stroke, and anti-atherosclerotic effects, and it improves insulin resistance due to all these effects. So this is how, when you give a combination of telmi and acylindipine, how they work together. It's very important. Absorption is they both act almost equally. They both get rapidly absorbed. Their dose absorption. The Tmax, the maximum level of acylindipine is reached in 2.2 hours. Telmi is 0.5 to 2 hours. Plasma protein binding is approximately 90% for acylindipine and 19.5% as telmi is concerned. Metabolism is primarily by cytochrome P450 for acylindipine, whereas for telmi it's different. It's by conjugation to form a pharmacologically inactive acyl glucuronide. Cytochrome P450 isoenzyme are not involved in metabolism, so they have two different mechanisms of disposal. Elimination half-life is 19.2 hours for acylindipine and 24 hours for telmisartan, is very long duration of action. The excretion 7 days post approximately 26% exit in the urine and 63% exit in feces, 7 days post dosing. And for telmisartan, 97% exit in the feces. Food effect, administration of azithromycin with food increase the extent but not the rate of absorption, and administration of telmisartan with food does not alter absorption. So it can be given, this combination can be given any time of the day, either with food or before food or after food, nothing will happen. So these two work so well together. And it really produces a 24-hour potent BP control. Telmisartan has potent blood pressure lowering ability and is effective in controlling blood pressure for 24 hours, even in the early hours of the day, which is very important because most of the strokes are and MIs are bound to occur only in the early morning. As far as circadian rhythm is concerned, when your cortisol levels start rising, you have a MI or a stroke. But it takes care of the BP at the early morning time. Azithromycin has demonstrated the ability of sustained and gradual lowering of blood pressure throughout the 24 hours. And this study, result study, which studies the combination of ARB and azithromycin as a fixed dose combination. This is to evaluate the antihypertensive effect and safety of combination of therapy with ARB plus amlodipine. It was evaluated in 1,202 patients over a period of 12 weeks. And what are the results? In the seated BP, azithromycin and ARB, they reduced the BP, but a combination of this was able to reduce the BP much better than either drug singly. Similarly, 24-hour ambulatory blood pressure monitoring, when it's being done, the combination of ARB and azithromycin, they were able to reduce BP much better, almost 50% higher than both the rest when they are given singly. So, additive effect of azithromycin and hypertension patients and unquoted ARB. You go azithromycin to patient who was already on ARB at that time. If it's not controlled on ARB, you add azithromycin. What happens? To assess the effect of ARB plus azithromycin on 24 ambulatory blood pressure control, it was again a study population of 1,202 patients over a 12-week period. It showed very clearly that additive effect of azithromycin is a 24-hour potent BP reduction. A daytime azithromycin and ARB combination very much reduced. Both systolic and diastolic are down by minimum 14 millimeter to 20 millimeter. Nighttime also it came down, and early morning BP also was down with this combination than when they are given alone. So to conclude, the proportion of patients achieving the seated BP goal was significantly higher in the ARB azithromycin combination groups than in the monotherapy groups. Results showed that combination of therapy with ARB and azithromycin was well tolerated and exerted a stronger antihypertensive effect throughout the 24 hours compared with monotherapy with ARB or azithromycin in patients with essential hypertension. And what about renal protection, which we have been talking so much? Yeah, microalbuminuria and proteinuria correlate more closely with abnormal 24 BPM measurements than with the clinic BP values. Clinic BP values may be low or maybe normal, but your kidney failure, you have to look only for microalbuminuria and proteinuria. They correlate well with that only, not your office BP measurements. Studies demonstrate that a potent 24 BP control can prevent glomerular filtration rate decline in patients. So only it's very imperative that you should check for microalbuminuria in hypertension patients frequently, at least once in a year. On all major trials, telmisartan renal protection, they have told very clearly that telmisartan has a very good renal protection effect. In the detailed study, telmisartan is not inferior to enalapril in providing long-term renal protective action protection in person with type 2 diabetes mellitus. In fact, even patients with type 2 diabetes mellitus who have a risk to develop hypertension, even though if it's not hypertensive, you can start him as mild dose of telmisartan. The innovation study has told that telmisartan reduced transition from incipient to overt nephropathy. The Vivaldi study has showed that similar proteinuria reduction 33% with both telmisartan and valsartan. Amadio study showed that albumin to creatinine ratio reduction significantly better with telmisartan 29.5% when compared to losartan 21.4%. All these 20 odd studies, they demonstrate very clearly the efficacy of temsirolimus in reducing proteinuria. The p-value is so high, so less when you do it with temsirolimus when compared to placebo. And diabetes and role of CCBs in neuroprotection is also a very important slide. In diabetics patients, the development of neuropathy blunts the N-type calcium channel mediated action of LN-type CCBs on renal arterioles, like cilindipine. When you give cilindipine to this patient of a diabetic, over a course of time, diabetic neuropathy, it blunts the N-type calcium channel mediated action of LN-type CCB on renal arterioles, resulting in altered renal macrovascular activity of this type of CCB. Whereas LNT type CCBs, like azilsartan, they dilate both afferent and efferent arterioles, which leads to a blood pressure independent decrease in glomerular capillary pressure. So, in a diabetic patient, I'd rather prefer acylindipine than cilindipine. This is what the moral of the story is. And again, this slide you already seen how acylindipine LT blockade and renal protection. It dilates both afferent and efferent arterioles in contrast to L-type channels. Therefore, there's reduction in glomerular capillary pressure more potent than L-type CCBs in reducing proteinuria and subsequent regression of CKD. And this both two study, this interesting study, which shows the ARP acylindipine, they give very good renal protection. It is to evaluate the efficacy of acylindipine versus amlodipine on diabetic nephropathy and atherosclerosis in type 2 diabetes mellitus with stable glycemic control. Acylindipine, but not amlodipine, reduces urinary albumin excretion and carotid atherosclerosis in subjects with type 2 diabetes mellitus. Blood pressure control with ARB and amlodipine is better. And not only that, it reduces urinary albumin excretion, prevents microalbuminuria, and it prevents atherosclerosis also. This study was done in a population of 38 people over a period of 32 weeks, and these are the results. The addition of acylindipine in type 2 diabetes patients and control on ARBs delayed the progression of urinary albumin excretion. As you could see, the urinary excretion was so high when ARB was given with the amlodipine, the black bars, whereas when you combine with ARBs and acylindipine, in the week 0 it's quite high. The week 32 is down to less than 200 microalbuminuria. And change of urinary excretion urinary albumin excretion also, when you give ARB plus amlodipine, black bar is higher, it increases, but when combined with acylindipine, it comes down. This again, addition of acylindipine, beneficial effects on urinary albumin excretion. As you could see, from compared to week 0 to week 32, in the combination of ARB and amlodipine, it goes on increasing microalbuminuria. But whereas this MCP1 is an antioxidant here, whereas in the ARB plus acylindipine, it actually decreases. And the TNF alpha, which is a classical immune modulator, the inflammatory hormone, this you can see there's again much decrease when you compare with ARB and amlodipine. So, additive antioxidant effect of acylindipine on angiotensin receptor blocker treatment for type 2 diabetes mellitus is the study to compare the effect of ARB combined with either acylindipine or amlodipine, which is better, on the 8-hydroxydeoxyguanosine, which is expressed in the kidney usually, aldosterone and liver type fatty acid binding protein, the LFABP, in hypertension diabetic patient with chronic kidney disease. This number of patients enrolled was 67, were contained over a period of 24 weeks. Here you could see in the acylindipine group, it was much lower in week 24 when compared to the amlodipine group. Both they showed reduction in proteinuria as compared to amlodipine, and this also reduction of 8-hydroxy-DG and L-liver FABP both show a greater decrease in case of acylindipine when compared to amlodipine. And addition of acylindipine in type 2 diabetes mellitus with CKD and control ARB resulted in greater reduction in aldosterone as compared to amlodipine. As we already told you, the calcium channel T, when it's blocked, it leads to reduction in aldosterone, greater reduction in aldosterone when compared to the L channel and the N channel, where this acylindipine easily scores over cilindipine and amlodipine. So, neuroprotection conclusions are acylindipine results in a greater reduction of albuminuria, plasma aldosterone, urinary 8-hydroxy-DG, and LFAB levels than amlodipine in patients with diabetic nephropathy. In diabetic patients, the development of neuropathy blunts the N-type calcium channel mediated action of Ln-type CCBs like cilindipine on renal arterioles, resulting in altered renal mechanism activity of this type of CCBs. Cilindipine dilates both the afferent and efferent arterioles, which I've been telling repeatedly, and that leads to a blood pressure independent decrease in glomerular capillary pressure. Cilindipine may ameliorate tubulointestinal injury to diabetic hypertensive patients with CKD, and only LNT type CCBs reduce aldosterone secretion as compared to other LN type CCBs like cilindipine. And what about cardioprotection? Yeah, in October 2009, based on the results from the on-target trial, telmisartan was the first ARB to be granted FDA approval for reduction in cardiovascular risk. Such a wonderful drug way back in 2009 when FDA gave approval for reduction in CV risk. And based on the on-target and the transcendent studies, the RAS blockade with telmisartan is shown to provide optimal cardioprotection in high-risk patients along with a good tolerance profile. And the various trials approved that only the on-target trial telmisartan was equivalent to Rampril in patients with vascular disease or high-risk diabetes. As per the transcendent trial, telmisartan was well tolerated in ACE inhibitors intolerant patients. The commonest side effect of ACE inhibitors is cough. We know about it. Many of our patients develop cough. So we are a bit hesitant to use ACE inhibitors as much as we would love to. But telmisartan fills that void so nicely. It's well tolerated in ACE inhibitors intolerant patients, along with significant reduction in composite secondary outcomes like CV death, MI, and stroke. And as per the PRISMA 1 and 2 studies, telmisartan is more effective than Rampril throughout the 24-hour period and during the early morning. Telmisartan is, in all counts, telmisartan is a more hypertensive drug than Rampril, as our elder teachers say. And the combined effect of angiotensin 2 receptor blocker and cilindipine, the J-core study, it is to test the hypothesis that angiotensin 2 receptor blocker and calcium channel blocker combination decreases day by day BP variability more than angiotensin 2 receptor blocker and the diuretic combination. Those are investigated the mechanism underlying the form reduction. You have two combinations. Number one combination is to use between the ARB and a calcium channel blocker. Second, ARB and a diuretic. Of these two, which produces, which causes less BP variation? This is the study. Comprised of 207 patients over a period of 24 weeks, and it showed very clearly that ARB plus cilindipine combination improved home BP variability in addition to home BP reduction. Reduction in home BP variability was partly attributable to the arterial stiffness reduction by this combination. Whereas one with the hydrochloric thiazide, it showed BP values are a bit higher than the ARB cilindipine in this study. And the additive effect of cilindipine on patients with uncontrolled ARB in the IORTA study, the aim of the study was to compare the effects of ARB combined with either cilindipine or amlodipine on central blood pressure and left ventricular mass index in hypertension patients. This is a patient number of 50 patients were enrolled. It was conducted over a period of 24 weeks, and it showed clearly that addition of cilindipine in uncontrolled hypertension patients to ARB resulted in greater reduction in central blood pressure and heart rate as compared to amlodipine. The charts, they talk by themselves. The change in central blood pressure are much higher in the ARB cilindipine combination compared to ARB amlodipine. Similarly, change in heart rate also was better with ARB cilindipine than ARB amlodipine. And addition of cilindipine in uncontrolled hypertension patients to ARB resulted in greater reduction in left ventricular mass index. It is being used more and more nowadays to study the beneficial effect of any drug. The respiratory effect is being studied by this, and is compared to amlodipine. Cilindipine was addition of cilindipine to ARB was doing much better when compared to amlodipine in ARB. The IORTA 2 study again showed the long-term results. 2-year follow-up results with this study showed that ARB cilindipine steadily improves LV diastolic dysfunction during the long-term therapy, and change in arterial stiffness was independently associated with improvement in LV diastolic function. And this is very interesting aspect of cilindipine, the relevance of baroreflex sensitivity. The arterial barrier reflex buffers acute changes of BP that occur during the postural change. When suddenly bend your head and patient who take hypertension medication, if he changes posture, looks up or looks down suddenly, the arterial barrier reflex, it takes care and it buffers the acute changes and patient doesn't fall down. It doesn't put arterial hypertension due to postural behavioral physiological stress and changes in blood volume. The impaired barrier reflex sensitivity can result in greater short-term fluctuation of BP. Impaired barrier sensitivity, it independently associated with poor CV prognosis. This all we know very well. Suddenly, patient reports a drop in BP, he has a fall. It's very ominous for the patient to have done so. And azilidepine, as compared to amlodipine, is acting very positive effects on the barrier sensitivity and arterial stiffness. The Valsalva reflects the sensitivity and the spontaneous BRs, both of them from the baseline of 4.8, it was Asulin was able to improve by 8.4, almost double. Whereas for in the amlodipine, this was just 5.5 to just 5.9. The spontaneous barrier sensitivity reflects study from 5.5 baseline to 8.2 in case of azilidepine, whereas in amlodipine it was 6.5 to just 6.3, it was less actually. So azilidepine therapy, but not amlodipine therapy, improved cardiovagal barrier reflex sensitivity evaluated in both spontaneous and the Valsalva methods. And shifting from cilindipine, if a patient is already on cilindipine, we shifted patient from cilindipine to azilidepine, what's the benefit in heart failure with preserved ejection fraction? The effect of switching is being studied in this study, evaluation of cardio-sympathetic nerve acting using by MIBG cardiac scintigraphy after adding azilidepine instead of cilindipine in patients with HF with hypertension. It was a 24-week period, now conducted in about 24 patients. It was observed that the washout rate in IMIG significantly decreased by azilidepine treatment compared to cilindipine treatment. These results suggested again that the cardiac sympathetic nerve hyperactivity was improved by azilidepine treatment compared to cilindipine treatment. So to conclude, in patients with hypertension and HFpEF, azilidepine improved the severity of heart failure and cardiac sympathetic nerve activity compared to cilindipine. Heart rate was decreased after switching from cilindipine to azilidepine. Azilidepine, as you know, it decreases the heart rate. This we have stressed even previously. So to conclude, the aspects of cardiac protection with this combination, ARB plus azilidepine combination elicited greater reduction in central blood pressure and left ventricular mass index compared to ARB and amlodipine. Azilidepine improved cardiovagal barrier reflex sensitivity as compared to amlodipine. In patients with hypertension and HF heart failure with preserved ejection fraction, azilidepine improved the severity of heart failure and cardiac sympathetic nerve activity compared to cilindipine, and heart rate was decreased after switching from cilindipine to azilidepine. The superior effect of ARB plus azilidepine therapy on central hemodynamics may be associated with more favorable cardiovascular outcomes than ARB and amlodipine. And what's the safety of these molecules? We know all CCPs have got their own side effects. How safe is azilidepine? Peripheral edema due to CP is such a common problem. Many times patient develop amlodipine edema. The most common dose-dependent adverse effect of CCP is pedal edema. It is thought to occur due to precapillary sphincter relaxation, causing intracapillary hypertension and exhaustion of fluids. It may cause withdrawal from CCP therapy. Patient may be so much perturbed by developing edema, he may even stop the drug and stop visiting you also. And in that peripheral edema with CCP, current issues are the dihydropyridine CCBs are associated with peripheral edema. There's no doubt. It's the mechanism of action. In a review conducted by Makani et al., it was observed that almost 10.7% of the patients on CCP report peripheral edema, and 2.1% of them withdrew from CCP therapy due to peripheral edema. Dihydropyridine CCBs have higher incidence of peripheral edema, that's 12.3% due to than non-dihydropyridine CCBs. Incidence of peripheral edema increases with duration of therapy and dose of CCP. The risk of peripheral edema is lower with lipophilic CCP, and significantly lesser incidence occurred with azilidepine. Only 0.09% experienced peripheral edema in a study of large number of 5,260 patients. So azilidepine is highly lipophilic, unlike amlodipine. This LT type CCP is because of its high lipophilicity, the pedal edema rate is 0.09% only. And there is no reflex tachycardia with acylindipine. This is very important because it doesn't increase the heart rate. It offers sustained and gradual BP control, acylindipine, and it reduces the heart rate. Many studies have proved again and again both smooth reduction in systolic blood pressure and diastolic blood pressure, and the heart rate also. This is able to achieve the same. And what's the evidence on approval? We study discuss so many things. Has it been, is there any evidence and it is approved? Yes, it has been approved. Of the acylindipine, 50 clinical trials have conducted. Randomized controls are 42. Human volunteers. All these studies have shown very clearly that acylindipine has similar number of published clinical trials as compared to cilindipine. Acylindipine has most number of RCTs as compared to cilindipine. So it's been approved by US FDA and PMDA. And what about our own Indian data? It's the India phase 3 randomized double-blind parallel group comparative clinical trial to evaluate the safety, tolerability, and efficacy of two fixed-dose combinations, acylindipine and telmisartan, when compared to fixed-dose combination amlodipine and telmisartan in patients with stage 2 hypertension. When we compared two groups of patients, one combination of acylindipine and telmisartan, second group amlodipine and telmisartan, the traditional combination. What are the results? The mean percentage of change in systolic hypertension in each group is seen compared to baseline. It's very good. Both of the drugs work beautifully, but they have is as good as effective as amlodipine in reducing the BP, plus all the safety features which I have just now enumerated. So our own Indian data support this combination of acylindipine and telmisartan. So to take home the messages, this combination has a potent 24-hour BP control. Telmisartan is a potent long-acting ARB with 24-hour control. Acylindipine is a highly lipophilic LT type calcium channel blocker with potent 24 gradual sustained BP control. It gives good cardio protection. Telmisartan is the first ARB to grant FDA approval for reduction of CV risk and with proven benefits. Acylindipine via LT type blockade reduces left ventricular mass index and heart rate. Only LT type CCBs like acylindipine reduce aldosterone secretion, which is very important point as compared to other LN type CCBs like cilindipine. And it offers good renal protection also in diabetic with development of neuropathy. It blends the N-type calcium channel mediated from the action of LN-type CCP on renal arterioles, resulting in altered renal microvascular safety activity of this type of CCPs, whereas acylindipine dilates both afferent and efferent arterioles in glomerular, thereby reducing the intraglomerular pressure, thus delaying the progression of proteinuria via LNT type blockade, and telmisartan reduces the proteinuria as well as an antioxidant properties of acylindipine. So when you compare all these things, when you study all these things, it becomes right from day one, when you want to keep the safety of the kidney and the heart, when you want to prevent and delay the cardiovascular complications and the renal complications, it's best to start the patient right from the day one on a combination of telmisartan and acylindipine, which are so good molecules. So it's much more important, to quote William Osler, it's much more important to know what sort of patient has disease than what sort of disease the patient has. So my last slide, and thank you for your time and the presence. I am ready for questions now.
Thank you, sir. Thanks for an insightful presentation on ensuring cardiovascular and renal protection for your hypertensive patients. Now we open the forum for questions, sir.
Good evening, Sekar'S.
Boss, good evening, சொல்லுங்க. Yes, boss, good evening.
தூள் கிளப்பிட்டீங்க. But என்ன டைம் கொஞ்சம் எக்ஸ்டெண்ட் ஆச்சு தவிர we have covered everything from basis to இது. We have emphasized the importance of ARBs, telmisartan and CCBs, acylindipine very effectively. Its efficacy, safety, tolerability, everything. And how it scores over C-type, L-type amlodipine, LT-type acylindipine, how it scores, what is the importance, and the aldosterone, prevention of that secretion, everything, and this arteriole, afferent arteriole dilatation, so many things. We were highly focused on the importance point, everything. So, like Laurel and Hardy, the perfect combination, this Telmi and acylindipine makes a wonderful combination. Dio really for diabetic hypertension, it has a say on it. There is no doubt in it.
No doubt, yes.
Even now, yesterday I had a patient from other doctor. He is using nifedipine even now 20 milligram.
Oh God.
Yeah, this is the way it goes. So for this type of people, we need to emphasize this type of CMEs will help them to adapt this benefit, pass on these benefits to the patients. But I want to ask only one thing.
Yes,
You have made a wonderful comparison between the cilnidipine, amlodipine with cilnidipine, but safely you have forgotten to compare with benidipine. I don't know why.
but depend acts on all the three channels. All the
Yeah, but you didn't.
Studies are yet to come. It's not as much studies as cilnidipine. Studies are yet to come. Because
There
that was
are
that. Because there
there
was
are
that
40
kind of
studies now.
No, I didn't. This
With the
was fake.
benidipine, there are 40 studies are there.
The-
With the cilnidipine, there are 32 studies. Anyway, cilnidipine is good. There is no doubt in it. But you didn't want to compare this benidipine and cilnidipine. Anyway, thank you. All the best, boss. All the best.
Thank you, boss.
Sir,
I want to.
there is a
I want to
question
make
in
very
the chat,
clear
sir.
about. I want to make very clear, patient to understand, people to understand this L type, N type, and T type channels. So I spent about 5 minutes on that. So only, but unless you understand those L and N type, T type channels, you can't understand why this is superior, is a better molecule than cilnidipine and amlodipine. That's what.
Yeah, exactly, boss.
Sir, there is a question in the chat box, sir.
Yes, sir.
Dr. Palnichami sir has asked, will this wonderful CC be useful in atomic neuropathy, PAD, microangiopathy?
So all these conditions, they show extreme cause of insulin resistance and disease progression. This in the early stages, it may be able to reverse that. But as the disease progresses more and more, this may help to decrease, but it may totally revert. But in the early stages, it can revert macroalbuminuria. There's no doubt about it.
Sir, actually, sir, regarding this, sir has talked about benidipine actually. Muralidharan sir. Really, sir, we also had a discussion with some of the doctors, those who are using benidipine as well as cilnidipine. What we felt, no, sir, the way they're claiming the blood pressure reduction was not that much what was mentioned in the benidipine to Indian patients. But there are a good number of patients has achieved a blood pressure reduction with cilnidipine, which was that doctor has observed, sir, there is a good reduction in blood pressure reduction.
I'm using it personally for the past few months. It's very, very
And
good.
pedal edema, actually, the one doctor has put around 150 patients, and he told the frequency was not even 1 or 2 also. He has discontinued cilnidipine. So patients are compliance is very good actually in terms of
My patients are very comfortable with cilnidipine. There is no doubt in it.
yes, sir.
Improved adherence is there, and there
But
is.
one thing is main thing is cost only, sir. That is
exactly.
So that is a major disadvantage of cilnidipine. But still, if you patient having better compliance and better BP reduction, this instead of triple drug, they can go for this double drug, and particularly plain is available, sir, with us actually 16 mg. But most of the studies has done with the 16 mg because blood pressure reduction with 16 mg is remarkable blood pressure reduction, double digit reduction as shown, sir. So that's a feedback from most of the doctors. Now it is 1 year now, sir. This drug has come now in the market.
But you pharma people, if you are able to reduce the price, we can pass on the benefit to more number of patients.
True, sir. True. Yeah. So that will come only, sir, when the drug is used very well, acceptance and doctors are writing. Then no, sir, everybody will come into the market, and definitely that will have an internal competition. It will get reduced, sir. That is what the way things are happening in Indian scenario, actually, sir. Thank you, sir. Thanks for a wonderful presentation, sir. This is actually elaborate presentation on hypertensive management.
Yeah.
Yes, sir.
Thank you.
Thank you, sir, there is one more, sir. Kindly share your clinical experience regarding. Tell my, sir. Your any of your patient you tried, sir?
I've been trying for the past 2 months. It works absolutely fine. Yes, yes. Not a problem.
Right.
And nobody
Thank you, sir.
had.
Thank you so much, sir.
Yeah, thank you. Thank you, Aditya.
Sir, thanks a lot, sir. Good night, sir. Thanks
Thank you.
for
Good night.
sharing your valuable time with us, sir. Thanks a lot, sir.
Sure. Thank you. Thank you.
Thanks to
Thank you.
everyone.
Sure. Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.